about this, so hopefully I'll answer a lot of the questions that are kind of burning. This can be life-saving. The blood is already there, just not in the right spot. Oh, what's not liking my... Oh, is this now plugged in? This one's a clicker one? I'll just go through. Just that clicker won't... Well, I just have to manually do it? Yeah. Okay. So again, I've already now found out that, access to blood for you guys isn't that easy. So this is where these transfusions can be very life-saving. Who feels confident doing an auto transfusion? Who's done one? Couple of hands. It's something you don't, for some of you, be saying, what even is an auto transfusion? It's giving patient their own blood back. You collect it from the abdomen or the thorax. We filter it, and there's different levels that we can filter it to, whether you're just using a standard blood filter, and you reinfuse it immediately. So it's warm as well. We're not pulling cold blood out of a fridge and giving it to an already critical patient. There's no cross-matching needed because it's compatible, it's their own blood. There's no other risk of giving them something they don't already have, I guess, unless it's contaminated, but I'll go through that. And apart from the time it takes you to get it out of the body cavity, there's no delay of waiting for a donor, trying to collect from that wriggly donor. You can get it out pretty quickly. When we consider it is when we've got active hemorrhage. Heme abdomen or heme thorax are the two big ones. Bleeding neoplasia, so again, question yesterday about that. I'll go through the evidence on the risk of seeding and the possible contraindication. A rodenticide case, but we make sure we've got them clotting first. You're not going to stick a needle into a coagulopathic patient. And when the donor, when we just purely don't have donor blood available, we instantly restore the circulating volume. It buys time to take that spleen out, and so you're stabilising them for surgery. And it prevents death from hemorrhagic shock. So sometimes we do this palliative care. If an owner's they've been diagnosed with a splenic mass, they may not want to go to surgery, or there's signs it's already in the liver. We've got hemangiosarcoma, but they want to have a few days to say goodbye. We may auto-transfuse them and send them home. That last comment there, it restores oxygen carrying capacity, and there's a little thing to know about the difference between stored blood and blood that hasn't been refrigerated. Once the blood is stored, it loses your 2,3-DPG, which is a little part of the red cell which helps unload oxygen at the tissue, at the level of the tissues. So without that, the hemoglobin holds on to oxygen, and even though you're giving a blood transfusion, or blood out of the fridge into a patient, it takes them about 12 hours for the red cells to regain this ability to let go of their oxygen. So if you're giving auto-transfused blood, it hasn't lost that ability. So you instantly got oxygen carrying capacity and unloading better at the tissues, which is a nice little fact, makes you feel a bit happier. Also, you're not giving them a heap of foreign proteins that aren't their red cells, aren't their albumin. Their immune system isn't working on overdrive dealing with this foreign transfusion. They're just getting their own blood back. So if we are using it to treat shock, they're going to come out of shock, and the signs of your perfusion parameters are going to look better a bit quicker. So again, no compatibility issues, no immune system being switched on overdrive, less risk if they ever need a future transfusion, so we haven't filled them up with someone else's blood already. It's warm and not cold. But once the blood, if a patient's bled into their chest or into their abdomen, it defibrillates very quickly once it's been in contact with a body surface. So it's not in that body cavity and all clotted. when you take it out, when you pull out a heme abdomen, it's already anticoagulated, I guess, itself. If it's actively bleeding and has had time to defibrillate, that's the time we'll put in anticoagulant with it. So if we, say, are in theatre and the surgeons are trying to get a liver lobe out that's going to actively bleed, I'll be ready to mix it with anticoagulant in my syringes, which I'll teach you the dose rate that you use if you do need to anticoagulate it. If you don't need citrate and it's already obviously not clotting, I don't add citrate to it because the patient just has to deal with that citrate and it can bind and chelate your calcium and you end up with low calcium, which in any massive transfusion, if you have low calcium in these patients getting a lot of blood products, it is got a negative prognostic indicator. They do better with a normal calcium, and so we may actually even give calcium if we're getting a low calcium. And a less immune modulation. The cons, the risks of an autotransfusion is if that abdominal blood is contaminated with gastric contents, bile, urine, bacteria. Even then, there's actually been a lot of studies done, especially in war situations from gunshot wounds, is that blood can go back into them, even if it's not filtered and the patient still survives, which is just amazing. We run ours through, we do use the leukoreduction filters, which I'll show you. They're blood salvage filters. There's a certain type of leukoreduction filter that we get. So if we've got any worry of contamination, generally for us, we kind of aren't, we wouldn't risk it in a situation like this. We would use blood bank products. If there's masses of hemolysis or microemboli that you aren't taking out by filtration, so that can be a complication. If there's a lot of inflammatory mediators and it's old, the blood has been bleeding into that abdomen slowly for days or even a week and it's already breaking up itself, that can cause coagulation abnormalities in your patients through overwhelming the inflammation from those broken up red cells of the older blood. The recipient, they are the recipient, they're getting their own blood back. That can really cause arrhythmias and problems, so we don't do it if the blood is very old. And also just it takes a little bit more time than just getting a unit out of the fridge, but it doesn't take that long. Our team, our nurses now are pretty slick at this. They kind of do it almost for the vets because sometimes the vets are, either they're some of our emergency vets who may not have done them as commonly, and they just feel a little bit daunted by it, but it's not actually that hard. I'll show you as we do them in some videos. The question about what about if it's cancer, it's something where, again, 1975 was this one case report of one human having a lung cancer resected, and they did see some neoplastic cells in the collected blood. They then put two and two, they assumed that those neoplastic cells, if we reinfused them, that they would take that cancer and spread it to distant organs. They've since done a lot of studies now in animals and humans to show that this doesn't truly happen. Especially if you use a leukoreduction filter, or even the machines now, the cell saver machines that take the blood out, wash it and very quickly give it back. You're taking out any abnormal cells. Only red cells are allowed through that process, so through these leukoreduction filters. So we now know that there's no increased risk of metastasis, and some of them actually have a better outcome because their immune system hasn't been modulated by giving them all these other foreign proteins by a transfusion that wasn't their own. Oh, there goes my belt. The cell saver and leukoreduction is even safer. So it really allows the patients to, we know we've taken out any damaged cells then. This is just one of the studies showing reinfusion of salvaged blood has not been found to promote tumour dissemination or distant metastasis when used in patients with substantial blood loss Salvage blood can be cost effective, and it can be used in adjunct to allergenic blood resources. So when I talk about this old blood, the times I don't do it is if the patient has been slowly bleeding over days or even a week, is that old blood has inflammatory mediators in it, and it comes out looking quite dark and horrible. There's complement fractions, there's cytokines, there can be fat particles from the omentum, there's free hemoglobin. You imagine those red cells in there have had time to lyse, so giving a lysed red cell isn't going to help us, and it actually can make that patient worse. It comes out and looks blacker, it doesn't look like nice red blood. I wouldn't retransfuse this. So sometimes you want to take a little 5 ml sample from the abdomen or the thorax to see what quality of the blood is in there before I spend the time to take it all out. The blood defibrillates after 1 hour in the abdomen or thorax generally. So normally if it's been the patient, the history is that they've collapsed at home, they've had generally kind of from the history determined they've had a bleed. They've then seemingly recovered and seem okay, but when you come in and assess them, you can see a big heme abdomen, their PCV's dropping. If it's actively bleeding, we do use the anticoagulant. A rough rule of thumb, this is the range we give between 0.5 ml and 1.4 per 10 mils. I just do easy maths in my head. I take all our staff, we do 1 ml per 10 mils, or it's 0.1 of a mil. Per mil. If we're going to say we've had a traumatic heme abdomen, we've got a bleeding spleen or liver, we're hoping it'll clot itself off and we just need to stabilise that patient with some blood, we're just going to use a normal 200 micron blood filter. If you're in a situation where it's life or death and you don't have a blood filter, I've done it, I have given it without filtering it before. It's not ideal. And these blood giving sets aren't that expensive. They've got long, years. Get a couple on the shelf and keep them in your clinic. So I would do this as best practice, but if you had a patient dying, you could get away with it. The hemonates, again, there's a few different techniques of different syringe options of getting it out, and there's a lot of different ways to do auto transfusions if you get imaginative with what supplies you have in your clinic. The concept is just getting blood out of one cavity, somehow running it through a filter and getting it back in. The hemonate filters are only good for small volumes. Technically, you're meant to change them every 50 mils, which does get a bit expensive, but I'm very slow to push it through. I don't bolus when I'm going through a little blood filter. It's better if I'm only getting, say, a small dog, like a 5 kilo dog, I'm only getting 100, maybe 150 mils out, I might use a hemonate filter then. Normally I'm putting it into an emptied out saline bag, or they now Mylar, the company Mylar, have really lovely auto transfusion collection bags, which I'll show you one. These are the leukoreduction filters. They take everything out, like I said when I was storing our blood, it takes out your white cells, your platelets, and tumour cells. So they can, and these type of ones, the blood bag ones, they do very slow gravity fed, which is not great in an emergency situation. But I found these online. Like, I didn't know these existed until I was hunting one day. It's Haemonetics and Chirumo are the two companies that I've found with these. And you can pressure infuse through them. So you need to get your blood out into your 1 litre bag. Then you just see the spike on the end. It spikes in, and the blood has to go through this first before into your patient. A really simple, the common way that we most commonly do our auto transfusions is just called a flippant drip. You kind of think about it up the top here. You've got an emptied out saline bag. It's just got a standard giving setting to get the blood into it. I'm not worrying about filtering initially because I'm just getting blood out of the dog. You've got a 50 ml syringe with a 3-way tap, and then you've got another extension kit onto either catheter, a butterfly catheter, or just a needle. So all of you, I hope you would have this stuff in your clinic that you could jimmy up together. Once it's out, then you're filtering. I'll show you this video. So this is a heme abdomen. We're getting ready to go to theatre. I'm just popped in there with my 14 gauge catheter. I've made a few nicks in it, so it's running nicely. I've got a nurse pulling out. Once they've got 50 mils or best part of a syringe there, they're just turning the three-way tap and they send that blood into the bag. The mylar bags, they're mylar bags that are lovely for this. They've just set up so it just makes that three-way tap redundant. You can just pull, push, pull. It's all got one-way valves in it. And the bags aren't that expensive, the mylar transfusion, auto transfusion bags, and we use them when we're draining chests as well. They're really nice. So again, then we're going to hang that blood, and then it's when we're filtering it going back into the patient. They get their monitoring done like we would a normal transfusion, just in case there was any contamination or any problem. We want to still see how they are. We don't just hook them up and go, but we're probably not as diligent. We'll watch them for the first 15 minutes, then we get it back into them pretty quickly. Again, you get it, that's a whole litre, and sometimes those big dogs, we might have 3.5 litres in an abdomen. To have that much blood on hand to save that patient, and how many different donors and how much cold blood would have gone into them, by far the best thing is giving them their own blood back. Here's another heme abdomen. We're starting to give some of its own blood back as we're getting into theatre to get more stabilised. Starting to get arrhythmias already in that one, which we'll go through in our ECG talk. There's another video, which we might just get the audio on this video.
The biggest concern we have is that Billy's gums are almost white.
This is one of our emergency vets. He did like the camera a little bit, so I've nabbed some of his videos. This was a traumatic heme abdomen, been hit by a car. Sure. This video does keep going. He was able to go in, just ultrasound guided. You find the deepest pocket, really. He's got his little catheter there that he's made the few nicks. You're going to pop in, prep the skin first, pop in, your stiletto out, and then pretty much just away you go. He was able to visualise the end of where his catheter's sitting, but sometimes once I'm in, as long as I've got my stiletto out, I don't care where it goes. It's not going to cause too much harm in there if you don't keep a sharp needle on the end. Then there's a few different ways. You can either go straight into a bag. If I'm wanting to, but that bag is kind of there waiting until it's best part full. If this patient's critical, I have another bag that I'm starting, and I might just start giving a few 50 ml syringes into it so that it's going into them quicker than waiting for me to get a whole collection. But I've got a blood filter on that new bag that I'm starting with them. Getting pinker and pinker as we give their own blood back. This is again he was a junior vet at this time, and under the help of the nurses gave a lot of our vets some more confidence. And now pretty much all of our emergency vets are very confident doing an auto transfusion. This is to show this is actually a theatre case, so we were trying to stabilise a bleeding heme abdomen in a little white fluffy to get to theatre. And initially we'd auto-transfused it, out in our treatment areas, and it just kept bleeding out. That whatever was bleeding in the abdomen was really bleeding with a vengeance. I ended up having to go into theatre. This is me here pulling. I was continually pulling blood out, and the team were handing those syringes on. We had a setup, and again, we just MacGyvered this. We had a setup where I'd hand it to Zoe, she'd put it into the bag, and then someone else, so that we could get it in quickly, someone else had a 50 ml on a three-way and would pull 50 mils out of the new bag I'd put it into, and then bolus it into the patient, just because we were dealing with smaller volumes. If it had been bigger, we could have put a pressure effuser on it. But this patient was actively bleeding out as fast as we were putting it back in. until the surgeons could save the day, and it was actually a bleeding spleen splenic mass, and they were able to quickly get that out, and then the patient stabilised. So think outside the square, you use what you've got in your clinic, and Zoe was my right-hand man, she's my blood bank nurse. You can come up with different setups. Because this patient too, while it was actively bleeding in theatre, we were having them, once I was collecting with a catheter out the side where it was pooling and they made their incision in, but once they were in, we handed them a syringe with an extension on it, and we jimmied it onto a little suction end so that we had anticoagulant in our syringe, and we were able to anticoagulate a fresh bleed. You'll see at the end, the next level we've moved up to, it was on my wish list for years to get a cell saver, which is the whole next level. In human medicine, if you come in and you've been a gunshot or a stab wound, and you're going straight through to theatre, in Australia, in every operating theatre, they have these cell savers, which they can put a suction tip in, they collect that blood, and they've got it washed and back to you within as quick as 5 minutes. So that's what I'll show you at the end, but this is the veterinary version that you make do. If you don't have your fancy machine to do it. This is the bag of anticoagulant that so the other thing by having a few blood bags on hand, you always have some anticoagulant. You waste a blood bag, but I was just drawing anticoagulant out of my blood collection bag. But you also can buy anticoagulant by the 100 ml or even by the litre and have some on stock to be able to do these different things with blood products when needed. Another technique, there's a JVEX paper, so an emergency and critical care journal. It's published as a 2-syringe technique. For any of you who do a little bit of large animals, this is the bigger kind of syringe with that bigger feeding, the tip off the end of it. It allows you to suck up blood really quickly from the abdomen. Then you just push that end into a normal 50 ml syringe and transfer it into there, then add your hemonate filter on. However, this is okay for smaller dogs. We'll hand a surgeon a heap of 50 mils and we'll say, collect what you can out of the abdomen in surgery and we'll give it back. Again, this is a modified technique. This was a bleeding adrenal mass patient in ICU that was crashing. These owners weren't going to go to surgery, but we were able to auto-transfuse it for the hour until they came down. So, I'm here with my catheter and a giving set. I had one nurse pulling it out, and then she would hand it over to the next nurse, we just had a standard catheter in, and reinfuse back in. So you can jimmy up whatever you can with a simple syringe, needle, and an extension line. You can pretty much, do whatever you can to save these patients, or sometimes, like I said, it's palliative care. This owner was able to come down and be with and say goodbye. Because, and again, it's appropriate use if you do have blood in the fridge. Sometimes, auto-transfusion is a nice palliative care without using up your blood bank, which you'd rather have on hand for the IMHA that works in, that we know we can hopefully treat and get out of here. So we do, once our units are getting a little bit older and they've only got a 2-week expiry on them, they go in, they can be used in palliative care units, palliative care cases. So patients with terminal disease processes that maybe it's just buying a little bit of time, but we are quite protective of it. We don't, the oncologists want to use a lot of blood, but we're a bit cautious. This is the future of autotransfusions. I was very lucky to get 2 of these ex-hospital, so at a very cheap price. They're about $20,000 to buy in Australian dollars to buy new. Pretty much what is happening, the big chamber on the left is your initial collection, and you can collect, the surgeon will be in surgery, you can collect and then you've got fluid and flush and all sorts of stuff going in. You get everything. If you've collected and we want to wash cells, say if that older blood that looks really black and I've had a heme abdomen and I've collected it out, I can put it through this machine and wash all that badness away, and you get just just the intact red cells back. The whole process, it's taken us a little bit to get our confidence up. It's not just a click and go. There's a little bit in your flow rates. We've had training, and we've now got a core group of us who are quite confident in this machine. I think we've got audio again on the videos, if we just turn that up. Just click through. So it's a Soren. The name, there's a few different brands. They're called Cell Savers. So if you can ever get your hand on one ex-hospital, you just need to buy the circuits and get some training, and you could do this in your hospital as well. What does it do? So it's collecting the patient's own blood, processes and washes it, gives you just red cells back, and it can do that in 5 to 10 minutes. There's a rapid setting where in 5 minutes it's washed it. And it returns home during major blood loss.
Come check this.
This is one of my nurses who put this together because they were so excited.
Come check this.
So it's anticoagulating at the same time as you suction up. We're filling up our collection pot, and you can start processing at any point. You don't have to wait for a full collection. It's coming down in here, it's getting washed.
Yeah. What's
and
this?
spun at
I
the
want you
same
to look
time.
for your red pack.
This-
Bath arm on the bottom.
There's a
There's a
red
red
pack coming at the bottom.
So what it is the red pack's on the outside pushing everything
Any
internally.
of the washed and
So this would be a
Hemolyzed
plasma plate that's
crud
going up
from the
red
tumour
cells.
is going
So
into
there
a
shouldn't be
waste
anything
bag.
coming off that. If it's fresh
A
blood.
lot of it's automated.
So
The
it
machine
can show you.
knows what it's doing. It's sensing. It's checking the PCV the whole time.
Include
You're
the
getting
blood
the
sensor.
PCV of the fluid come up. It's pretty nifty. We've been very excited to have these. Have you got these, Chris, in SASH yet? No. And you then get your red cells back, which are very healthy without all these inflammatory mediators. Especially the other thing, all cancer cells go. If you've got a contaminated abdomen with blood, or gastric contents or urine, you feel pretty. They use this commonly to wash and make those cells safe. So removing inflammatory mediators, free hemoglobin, avoids any storage lesions, gets rid of any clots. The other thing is if you've had big clots in the abdomen where that splenic mass has been trying, they actually salvage blood. He got a clot and we kind of smooshed it all up, sucked it into that suction pot, and we were able to get a lot of blood out of the clot. You can, if the surgeon has been using swabs and there's a lot of oozing, you can put those swabs in saline, mix them around a bit, and you suck the bloody saline up and you'll save those red cells. It's really impressive. Cleaner, safer, packed red blood cells. So it's still their own blood going back. So our key take homes is it's simple and life-saving auto transfusions. Anyone can do it. Use getting in, like contacting Terumo or Haemonetics to get in some leukoreduction filters, so you just feel a bit more confident in those neoplastic situations. But it's not a contraindication. And keeping an eye out for any of these machines ex-hospital if you've got any contacts in the human world. Again, I've got a bit more time on this talk for questions, so we did go a little bit over on the last one, so maybe 5 minutes of questions, and then we'll move to morning tea, I think. Questions? Hopefully I've answered them all. There is some stuff out there on auto transfusions. If you go online, there's different resources, but to be honest, it's getting in and doing it with this one.
We are once again open for questions, so if you would like to ask anything, you can.
So at what rate we can transfer the blood? So is it be fast? It can be fast, or like we have done the same manner, like 1 ml per kg per hour.
Sorry,
So the transfusion rate.
transfer or
So we have collected the blood from the abdomen, right? So we gonna transfer it to the patient, right? So at what rate can we infuse the blood?
So you start slow, so you're giving it back into the same patient. We started about 1 mil per kilo per hour, so slow like the other one, but I only start slow for the first 5-10 minutes, then I turn it up quickly. And if they've acutely bled, I'll give it very quickly back. Otherwise, give it back over a couple of hours. Normally, they've been in acute bleed because they've got it there ready to go, so I'm pretty happy to give it back quickly. Yeah.
Thank you.
All those who are leaving the hall, it's a request that kindly do visit all these stalls, collect your stamps and signature, drop that lucky draw coupon into the drop box, which is at the registration. Thank you. If you wish to ask anything else, you can. Okay. Thank you, ma'am. Thank you, Dr. Ellie.
Hello. One question, ma'am. Hello.
Yes, let's give a huge round of applause, of course, please.
Hello.
Yes, yes, sir. Sir, wanted to ask.
Hello, madam.
Oh, yep.
Okay.
Hello.
My question is for yesterday's talk, when we showed the dog bite wound on the left side of the chest of the dog, the lung was punctured.
Sorry, but...
It was yesterday's talk.
Yep.
So in that case, there was a dog bite wound on the left side of the chest of the dog,
Yep.
and lung was punctured. So you tried putting a stitch over there. So in that case, do we do a partial lobectomy?
If the lung is punctured, yeah, they generally have a lung lobectomy. So those dog attacks where they've actually, you're concerned about penetrating trauma and the patient isn't stable, we will definitely recommend and explore and lavage and lung lobectomy if that lung is affected and leaking. Yeah.
So if lung is more than 3/4 affected on the one side of the chest cavity, how do you manage the tidal volumes? Or do you put the endotracheal tube to only one side of the lung?
We would be in a pressure mode, and again, you're trying to do especially when we're doing lung lobectomies, we're using the least pressure possible, so you want conservative settings. But if you're in a pressure mode, the tidal volume is the variable depending on the extendability of the lung. So it's a safer way of letting the body determine the tidal volume, because that lung, the good lung that's left, will only stretch so much. It's not like you're telling in a volume mode. If you told it to give a big tidal volume, it's going to keep going till it gives that. Whereas pressure, whether you've got one lung or two, it'll match that to the pressure it's giving and stop at that pressure, which is much safer.
So in such cases, don't you use MICV PCV mode?
Sorry, a synchronized.
SIMC PCV mode?
Yep, so synchronizing is just synchronizing more with the patient. So if the patient is about to take a breath and trigger, and you're coming due a mandatory breath, it's going to synchronize that up. It doesn't change the amount of pressure that it's giving, except in the spontaneous. So say if they're breathing more than the set rate, the extra breaths, they only get a little bit of support, which is, it is gentler on them, especially if we're weaning. But sometimes a synchronized mode is the same as a mandatory mode if they're not taking any extra breaths, because they just get the set rate. So in a patient that's under anaesthetic and getting a lung lobectomy, they're probably not, we've probably hopefully got them matched and not triggering on top. I use the synchronized mode a lot when I'm weaning and wanting them to take more breaths. Yep.
But that time, do you increase the respirations while weaning the patient from the ventilator?
Which with the respirations?
Yeah, in any surgeries,
Yep.
if we want to get the patient back the earlier, do you increase the respiration of the patient and increase the PEEP pressure?
Depends. If their carbon dioxide is rising, I'll increase my rate or my pressure if I want to give a bigger tidal volume. If they're quite stable, as they're waking up, I'll start turning it back. It really depends on what they're doing as to matching what the machine is doing to their requirements.
But then chances of barrier trauma that happens up?
Using very high, all your your lung injury. Volutrauma and barotrauma by giving too big a tidal volume is definitely a thing. You overstretch all the little alveoli, they release inflammatory mediators, and you get a lung injury from that. So being as conservative as you can with your ventilator settings and doing the least, you want to keep their numbers acceptable, so your CO2 and your oxygen just acceptable. Don't crank, you just, especially if they've got underlying lung disease. So if their lungs are healthy, they're lovely and stretchy, and they can take bigger tidal volumes and you've got less risk of injuring them. If their lungs have got pneumonia, or say it's been a chronic diaphragmatic hernia where the lungs have been all squished up, you'll get re-expansion pulmonary edema as they come, and you've got to be very gentle on those lungs. So the lungs they guide you onto how aggressive you can safely be or not. If we've got severe pneumonias and those lungs are full of pus, we're trying to be as gentle as possible on them. Versus a snake dog that's just paralysed. I'm a bit more comfortable if their tidal volumes run a bit higher to keep their CO2 down. Whereas a dog with diseased lungs, I may let them run with a CO2 of 60 as lung protective ventilation strategy. I'm accepting a bit high, like a not normal range.
Okay, last question. You do have a lot of exotic pets. So in different, like as compared to dogs and cats, we have the tidal volume calculated per kg body weight.
Oh, sorry,
So in such, you get a lot of exotic pets in Australia, correct?
exotic pets.
Yeah.
Why? Yes, I only treat dogs and cats
Yeah.
now.
Okay, so other than dogs and cats, if you want to calculate the tidal volume,
Yep.
so what do you do? Like you put it on the PSV Pro mode or something, and then recheck the lung capacity, and then accordingly put the anesthesia?
I would roughly go, like if you were ventilating, I'd be going for 10 mils per kilo, but I don't ventilate lambs or pigs or anything anymore. But 10 mils per kilo, I'd say, would probably get you out of trouble. But I'd look up that species of whatever you're wanting to ventilate and find out their capacity and their lung volume.
Okay, sure.
Yeah.
Thank you.
If a dog is developing acute hemabdomen, but upon collecting the blood, if the blood is hemolyzed, so whether you will go for auto transfusion, if not, and what would be your alternative options in that case?
That is then when you've either got to have blood stored now, hopefully, that you've got a unit in the fridge you can quickly grab, or another donor coming in. I wouldn't give them that hemolyzed blood unless you can get an auto transfusion, the cell saver, and wash it. You can washing cells in-house yourself, but you'd need a centrifuge, because all that machine is doing is actually running saline through those red cells and taking that, when you centrifuge it, and taking the top off. So you could, if you got yourself a centrifuge machine, you could quite crudely try and wash cells and get rid of a lot of that bad stuff of the auto transfusion, of all the collected blood. But to be honest, you're safer just to throw that, not give that blood back to them. It goes in the bin, and they get a transfusion from a donor. You get in their other dog, or and if you're running a blood donor program, screening your dogs. So infectious diseases are easily transmitted, and the last thing you want to do is have blood come out of the donor's other dog and making their dog sick, or if you've got donors in your program that are owned by staff and you unknowingly know that they've got a disease in them which wasn't clinical at the time, but then you make your recipient sick. So definitely screening.
And if you are having fresh blood with you, like fresh donor blood with you, so whether you will prefer donor blood or the blood from the same patient?
If I had the option and the blood from the cell, I would give an auto transfusion. It's safer for them. And as long as it's been a fresh bleed, or I could put it through my machine, it's safer for them than getting another donor. Yeah. And in human medicine as well, they now actually prefer to give you your own blood back. If you're a candidate for it and you're bleeding in surgery, they're going to give you your own blood back with one of these machines rather than giving you a cross-matched unit from a human. But in human medicine, do so much screening and so much cross-matching and compatibility checking before it goes in. I've seen them where they pretty much hang the unit and they don't even monitor you. They are sure that it's going to be compatible when it goes into you.
Is there any other way to check whether the blood is hemolyzed or not, apart from the color of the blood?
You can spin it down, and I forgot to mention that. You just put some in a hematocrit tube and you can spin it down and you grossly look at it. An acute bleed, the serum's pretty clear, maybe very slightly hemolyzed. An older one, it's very hemolyzed. So that's a crude way. If you can check free hemoglobin, but it's, you know, not many people have that machine to do in-house.
Are there any color assessment kits for that, like to compare the color?
Sorry, for the...
To compare the color of the blood, are there any?
Oh, yeah, don't know if there's any cheat sheets. I only do it grossly of just whether it looks mildly hemolyzed and very lightly pink versus quite severely. I don't have a guide. There probably could be or should be. You could make one up in your clinic if you're going to standardize at what point do you say you don't reinfuse those cells. Generally, it comes out and it just looks dark and you don't want it back into them. Yeah. And trust your gut. Don't give it.
Thank you.
Yeah.